I'm CEO and of the ALTIUS Answers podcast. I'm extremely excited to have Dr. Jed Constantz here today. Dr. Constantz is the principal of Advanced Primary Care Strategies. As a healthcare finance and delivery strategic consultant, Dr. Constantz has really spent a lot of time ensuring existing and prospective clients and primary care facilities receive maximum value from both their current strategies, but more importantly, from their future strategies and initiatives. Over his 30+ years in healthcare, Dr. Constantz has developed tools and resources for primary care providers and employers seeking to reduce costs, drive greater efficiency and quality outcomes, and thereby really create a network of primary care practices within their regions and communities that are there for the betterment of the community and healthcare initiatives. Dr. Constantz, thank you so much for joining us today.
Oh, absolutely, my pleasure.
I'd like to start, if you can just give the listeners a little bit of an idea of your background and your history, and then ultimately, how did you become passionate about what you're focusing your practice on today?
Well, I have been working in healthcare, as you point out, for over 30 years. I think I'm actually approaching 40 years. And I started my career with, did that disturb everything? Hang on.
If you want to just start with your background again, we can start from that position.
I'm sorry.
That's okay, no problem.
Yes, as you point out, I've been in healthcare for over 30 years, and frankly, I'm actually approaching 40 years. I hate to admit it. I started my career with one of the Blue Cross Blue Shield plans in Massachusetts. Frankly, as a training instructor, was supposed to be teaching in a high school somewhere, but that never worked out. So I took my training and development skills into the corporate world, and in this case, Blue Cross Blue Shield, where I began my journey of learning about healthcare finance and delivery from a purchaser or a payer perspective, I should say. And over that time, have had the opportunity to work both on the payer side as well as the delivery side, and have come to the realization that we have overcomplicated this conversation unnecessarily, and we need to truly consider an opportunity to simplify the conversation if we are genuinely interested in offering our communities affordable, high-quality health care that in some cases is employer-sponsored, and in other cases is underwritten through publicly funded programs. I had the opportunity to meet along the way some truly inspirational physicians, and in particular primary care physicians, whose common theme was if they simply had the right practice environment, they frankly would be ready, willing, and able to do some amazing things on behalf of the patients they cared for, and really meet the needs of those patients in collaboration with other physicians and facilities, but at the end of the day, remain loyal to the patient in a way that ensured that the patient received as much care and as often care as was suggested by their documented needs. And when you look at that in the context of where we are today, the level of healthcare waste that occurs, the confusion that exists among patients in terms of what do they need, where should they go, it struck me that if myself and my colleagues could help create a system that purchasers could use in order to genuinely deliver a better healthcare model, that made sense as something that I should concentrate my efforts on and dedicate myself to. And every time I've had an opportunity to bring together those who buy healthcare and those who deliver care in terms of primary care first, every time I've had an opportunity to be part of one of those projects and one of those programs, we have seen a meaningful reduction in the aggregate cost of care, the total cost of care. We have seen a measurable, simple, measurable improvement in the health status of the population, the patient cohort, the covered individuals, depending upon your terminology. And ultimately, we've seen a dramatic increase in the level of satisfaction that exists, not just with the patients who are being cared for in this environment, but also the clinicians who have an opportunity to deliver care in this environment. And so that's been where I have chosen to concentrate my efforts from this point forward.
That's fantastic. You talked a little bit about the waste in the healthcare system. And at Altius, we speak a lot about the fact that there are billions of dollars of waste, possibly $1 trillion of waste. And a lot of it is in the overutilization of specific healthcare, procedures, and for the lack of, focus on high quality. So there's redundancy in work, there's, tests that need to be redone, there's lost information, and just breakdowns in communication in every step. So I think there are a lot of parallels between the work that we do and the work that you're doing. I know that you've really focused on the primary care medical home, or the PCMH, and you've also really focused on those advanced care strategies. So if we can talk a little bit about before COVID-19, because right now we're sitting in a unique time, and I think the last 3 or 4 weeks have really transformed and changed how we're going to see primary care in the future. But let's just start, initially is, what was your long-term vision and goal, and what were some of the best practices that you thought ultimately had to be put in place for primary care to really evolve into being the center of the patient care experience and the coordinator of efforts? And we'll start there and then transition a little bit more.
Absolutely. Well, and you just said it in terms of coordinator. One of the simple truths around healthcare waste is often the lack of a coordinator, the lack of someone of sufficient knowledge and expertise to be able to guide the patient or the covered individual, depending upon, again, your terminology, through a healthcare experience that ultimately meets their needs. And the absence of that coordinator has created an environment, as I've said previously, where folks are just kind of bouncing around the healthcare system trying to figure it out on their own. The consumer directed effort, while understandable, was missing a key element in terms of the level of health literacy for the covered individual, for the patient, in knowing what to do, when to do, and how to do. And so, my idea of a good time for all sources of primary care is to create an environment where the patient, the person, has a trusting relationship with an actual doctor, who is then supported by a care team and practice level technology, so that once the physician deeply understands the needs of that particular patient, he or she is in a position to then bring in, through delegation and collaboration, a care team who can more immediately address the needs of that particular patient depending upon their risk stratification or their health status, and thereby provide that person with an ongoing system of support dealing with social determinants of health, a variety of issues that might cause us as individual patients to either work well as a partner in care with our primary care physician, or be somewhat clumsy and dysfunctional as a partner in care with our physician. And so when you look at what all sources of primary care have an opportunity to become, part of what we've worked on is creating objective criteria around which purchasers can make decisions as to which sources of primary care they would like to buy primary care from on behalf of their covered individuals, and what sources of primary care can look at to examine where they are presently and where they need to be in the not too distant future. So that type of information, I think, is particularly important to consider. And frankly, colleagues and I have been looking at this in the context of COVID-19 around, had primary care been able to demonstrate these capabilities, how much better patient decision making would have been around their own well-being and their own safety, rather than having to rely on government to tell us to stay home. We could have tapped into a trusting relationship who understandably would have been able to help us recognize the need to socially distance, as they say, or physically distance.
And whenever you speak about the purchaser within primary care, that can really have two different meanings, correct? It could be the employer who is ultimately
Yep.
purchasing a product for their employees, or it could be the insurance companies that are defining what the network would look like.
Yeah, and I've tried to adopt some terminology to kind of help with this conversation. Employers and government are the purchasers. Carriers, claims administrators become the payers. They become the channel through which the funds will flow. For a fully insured individual, the carrier, claims administrator, if you will, is to some degree more tightly connected to the purchaser. But at the end of the day, it's either publicly funded money, taxpayer money, or an employer's corporate proceeds that are underwriting the cost of care. And so the invitation that I tend to extend in these conversations is let's take a look at why it's important to buy primary care differently than you buy all other healthcare services. One of my catchphrases is primary care is an investment. The rest of healthcare is a payment. So if you are a purchaser, the extent to which you can understand that fundamental truth that primary care is an investment, you can then begin to understand why primary care needs to be than other healthcare services, because everyone, if you broadly define what primary care is, and in some cases I suggest that you include the definition of public health in the context of primary care, then everyone deserves a relationship with primary care and thereby services from primary care or support from primary care. And so to that extent, you recognize or begin to understand that no one should be without primary care. And as a result, the primary care payment needs to be calculated in a way that ensures that the relationship someone has with primary care is properly funded so it can be as robust as is necessary for that person.
I really like that definition of primary care and viewing it as an investment. I think for a long time within healthcare, there has been an emphasis placed on all of the specialty services, and perhaps we have undervalued the primary care component. And when you look at the collaboration and what we have seen happening with COVID-19, had primary care been positioned and held up as that first line of defense, there would have been a lot of different decisions, I think, made down the road, from the emergency room, from testing, from how individuals access those tests. But more importantly, just from understanding the community's need in general. I like the fact that you mentioned that you need to pull the public health aspect into the primary care definition. And along those lines, if you pull in the social determinants of health, I think that definition really begins to forge the future of healthcare, because now we have the public health infrastructure really rooted in a primary care philosophy of controlling what is best for the outcome of the community and the patient.
No, absolutely. And I had the opportunity to serve as the administrator of a certified home health agency. And it was through that experience that I began to understand that we were delivering home care services, but not doing it in true partnership with primary care. We were chasing a primary care physician's signature on something in order to get paid, not in order to do care collaboration, care coordination. And so it was an opportunity for me to really see the disconnect, and and which drove my motivation to try to address that, so that we were as home care, we were extensions of primary care and not external to primary care. So almost 20 years ago, I was innovating in creating a different kind of collaborative relationship, not just to get the doctor's order signed so that we could get paid, but to truly help that primary care physician begin to imagine different ways of leveraging the home care resource in order to enhance his or her ability to meet the needs of their particular patient.
I think that's a really important point. And viewing it from the home care perspective, I think, just from experiences that I've had with my mother and, other relatives and friends, I can see that definitely translating into a lack of coordination of care. They're just trying to get the payment on the actual visits, but not coordinating with the primary care doctor or physician when sometimes they don't even know what's going on. And I actually have experienced that also and seen it with clients and others in physical therapy context. When you're looking at physical therapy visits, there's a lack of coordination, and it's just simply chasing 5 or 8 more visits instead of truly talking about what is the right thing for the patient. And if you take that a step further, it can be, orthopedic surgery, cardiac care, where you don't really have synergistic discussions happening between all of the care providers for the patient. So I think this is truly an innovative way to understand, what the context is for the patient, but ultimately, how do you coordinate the care of the individual to have the best possible care outcomes?
Yeah, and so almost 12 years ago now, I had the opportunity to be part of an innovative program on behalf of Cornell University in their effort to address their year-over-year trend in medical spend. And so what we did was took a hard look at historical spending as an indicator of patient need and also healthcare waste, frankly. Discovered, lo and behold, that their benefit plan design was very siloed and drove fragmentation in how care was delivered to covered individuals. Invited them to consider delegating to primary care the opportunity to deliver services that previously had been provided by vendors external to primary care. And in order to create common language between the purchaser, in this case Cornell University, and the primary care community, we suggested that primary care be given an opportunity to think about care planning in based on 4 buckets of need on the part of the covered individuals. So we were suggesting that primary care be given an opportunity to care plan around stress, diet, exercise, and sleep, and to and then for Cornell to modify through payment reform the compensation strategy for primary care so that it gave Cornell the opportunity to spend the same or less money, turned out to be less money, more intelligently by channeling the investment in those types of services through primary care. And we saw some great things happen. We saw an opportunity for primary care to now begin truly whole person orientation around the needs, behavioral health through stress, and medication therapy management, to take ownership and take control over those things, which were cost drivers for Cornell under its benefit plan, and provide a better patient experience. Now, for me, at that time, I was working for a small community hospital, and it gave us an opportunity to reimagine product line development. We created a Center for Healthy Living to go along with the Cornell program for healthy living, which is what that benefit plan design was called. And it gave us an opportunity to be a supplier to primary care for capabilities that they were unable to develop either based on their size or frankly lack of working knowledge. So we created through our hospital supportive services for primary care. And the good news is we were mature enough to see ourselves in a different relationship with primary care, and gave us a play in primary care, which we thought was great. And 18 months into the program, Cornell had reduced its aggregate spend by about $1,500 per employee per year, which was a great deliverable on behalf of Cornell.
That's a large number. When you think it's some of the number of covered lives many hospitals or healthcare systems have, especially whenever they're self-funded, take $1,500 and multiply that times the covered lives, those benefits become really large. And I think what's fascinating to hear in what you just mentioned is that it was based on 4 principles. And those 4 principles are a lot of the principles that we're currently hearing about in the way that people need to embrace and respond to their own health and wellness within COVID-19. Right now, there's a lot of information on dealing with stress. So how do you decrease your stress and control your mindset and make sure you're in the right space? We're seeing a lot about diet and how do you make sure that you have the right nutrition and you have your immunity in place. We're hearing about exercise. How are you moving? And then ultimately in the fourth one, we're hearing, components of what do you need to do to, impact that as well. So you have these 4 pillars of, what individuals need to do. And it's exactly parallel to what we're hearing the industry experts say individuals need to do to make sure as we're sheltering at home, we're in the best health possible. So I think that's fascinating. So we're all experiencing this together. How do you, number one, what lessons do you think we've learned from our response to COVID-19? And then ultimately, what do you think is going to happen in the future and where should primary care go in the future?
Well, one of the first things that we've discovered through social distancing and the like is that folks are going to need to be able to access their primary care virtually, and not just because it's convenient, but because it's more efficient. And I tell the story of Dr. Christopher Crow from Catalyst Health in Dallas. I was actually part of a team that was interviewing him in order to learn what they've discovered as a result of this. And he has a fairly sophisticated community of primary care that he works with. And pre-COVID-19, telehealth for his community, only about 15% of his community actually had the service up and running and available. And among that 15%, only about 1% were using it with any regularity. Well, as of today, 90% of his community have it available, and half are using it with some regularity. The challenge that we're faced with right now is, are we genuinely able to create a payment system for primary care that recognizes that face-to-face office visits may well be a thing of the past, that certain patients will be seen face-to-face, but the simple majority of patients are going to be seen virtually in order to continue a level of physical distancing, social distancing beyond COVID-19 in order to better protect our populations from infection and from viruses yet to be identified. And so that's an important consideration to make. It doesn't lessen the need for primary care. What it does do is challenge us all in terms of what we consider to be how primary care and the way it should be delivered in order to meet the needs of people in the most efficient and effective way. I've always suggested, with some different reactions from folks, that there really is no shortage of primary care. I've instead suggested that it's just poor deployment of resources driven by a fee-for-service system that undermines the financial integrity of primary care because nothing is payable unless two things happen. Number one, a clinician of sufficient licensure is face-to-face with the patient. And number two, it fits a 5-digit code for payment. And so both of those realities at present undermine the financial integrity of the primary care practice and the true delivery of value-based care. So one of my observations has been that if we're going to do payment reform with primary care, it has to be more than just chump change. It has to be truly transformative, demonstrate that primary care is an investment, and provide the kind of cash flow that primary care needs in order to be available. So that's why I like to tie it to how we've often viewed public health. Nobody buys public health services on a fee-for-service basis. Public health is provided by communities, either through private entities or through public entities, where a calculation is made given the population in the community, and compensation is provided in advance to sources of public health. And so I think it's long overdue to consider that same kind of thinking in support of primary care.
I think that would change the conversation entirely, because if the thinking becomes, what is the amount of money that primary care should be funded based off the number of covered lives, you can entirely change how you plan your primary care practice, how you plan the services for your patients, and what you're ultimately doing. And I think in addition to telehealth, there's a lot of innovation that has occurred just over the last 2 to 3 weeks with in-home monitoring of patients. There are a lot more pulse oximeters that are available. There's a lot more home blood pressure checks happening, a lot more sugar checks happening. So all of these things, whether it's through, iWatches, other components, I think we're seeing rapid change, within healthcare over the last 2 to 3 weeks, and that's going to just continue to evolve. So I think post-COVID-19, primary care is going to look different from pre-COVID-19 primary care. And I think all of the points that you made about where that future is going to go are really important. At ALTIUS, we spend a lot of time focusing on staffing levels. And I think it's safe to say that the way that we have staffed primary care practices, for the most part, hasn't really changed over the last 20 to 30 years. Even with the change in telehealth and EHRs and some of those things, we still staff them the same. You walk in, there's a receptionist sitting at the desk, they check you in. Someone else will take your vitals and take you back to the room and let you, into the practice where you sit and you wait, whether that's, an assistant, you have an MA or someone, then you have someone else that's going to check you out before you leave the practice, and there might be multiple other steps in there. So we've always operated on those ratios, whether it's you have 2 support staff per primary care physician or 3 support staff, or err on the side of being overly staffed, whatever it is. That's the old model. It's been in place for 20, 30 years. How do the changes that we've now implemented over the last several weeks, and how do the staffing patterns change for the future? What does a primary care practice have to do, and how do they evolve their staffing to really embrace this model and be positioned for success?
Well, part of the exercise that I refer to as calculating the future value of primary care is developing a deep understanding of the needs of the patient cohort or the target population. And so, we learned this through the Cornell Program for Healthy Living and continue to see this to the present day, where if you have the right kind of data system that allows you to deeply understand the needs of the population, then you have the right type of strategic planning information that helps you understand what the practice configuration should look like. Do you need on-site behavioral health support, or will your staffing model permit a virtual relationship instead? Again, given the documented needs of the population. But beyond that, once you figure out the configuration of the care team led by a physician, you then need to understand what are the skill sets that are needed by the care team based upon the needs of a deeper understanding of the needs of the population. I have an undergraduate degree in education, master's degree in human resources. So I'm all about staff training and development. And I believe that this is an opportunity to look at the redesign of position descriptions that exist within a primary care practice in order to more fully respond to the needs of the covered individuals. And so part of the purchasing criteria that I helped author through the National Alliance of Healthcare Purchaser Coalitions focused on 4 components of practice operations. Obviously, physician leadership at the practice level was the first, the staffing model was the second, practice level technology was the third. But the fourth, as a component of continuous quality improvement, was ongoing staff training and development. Once you have your team in place, you need to make sure that you are making the right kind of investment or commitment to ensuring so-called top of license ability, so that if team members need to be trained and developed based upon insight around the data for the needs of a particular patient or cohort of patients, that you have that ability to continually train staff, retrain staff, and enhance their capabilities to meet the needs of that patient population. The kind of off-the-shelf staffing information or configuration that you've alluded to really been driven more by revenue than it has by need. And so the work we've done around comprehensive payment for primary care genuinely focuses on care that's aligned with the needs of the population rather than care that's provided. Uh, and so I think to allow patient need through a comprehensive payment model to infect some of the decision making around what the practice needs to look like in the future is a perfect opportunity to really make sure that you are designing something that genuinely meets the needs of your community. And so for hospitals, I've had an opportunity to work with hospitals who are able to see themselves as employers first and hospitals second, thereby leveraging the insight and the intelligence that they can gather and gain from their own covered individuals in order to design something that meets their needs as an employer, and then ultimately offer that solution or strategy to the broader community of employers that surround them. I think that that lends itself to solidifying the position for the community-based hospital as a valuable community resource.
Yeah, I definitely believe that looking at it as a population-based component and understanding what do I need for my cohort of patients, which may in fact be your employees, but what do I need for the cohort of patients so I can provide the best possible primary care network, completely flips the staffing discussion around, because now it becomes, what do I need for this unique population in my town, which is going to be different from a different city, and it's going to be different from another healthcare system, and it's based off of our demographics and our patient characteristics and what those patients ultimately need. What comorbidities are they presenting? What are their environmental situations that are impacting their health? What do we see in the social determinants that makes us unique? And then it completely changes how healthcare in general really sees those conversations around what do we need for our individual patient population. So I think that's very insightful and definitely where healthcare is going to go in the future.
Yeah, and more than just the staff, the physician needs to be evaluated from their ability to delegate and collaborate with team members. It's an important skill set, often found in business, uh, but more often becoming absolutely critical to the successful delivery of primary care. That physician's comfort level with asking a team member to carry out a particular activity and task is important. And then knowing how best to interact with that team member to make sure that everything is on course and that patient needs are being met, not by the doctor, but by a team member.
And I think you touched upon something in, what you've been mentioned. It's really important to note that a lot of this relies on the physician's comfort level with their individual staff's competencies and ability to carry out the needs of the patient. And in order to have that comfort level, it's really rooted in education and training. A lot of times we miss the fact that in order for our staff members to do what we want them to do effectively and to do it to the best of their ability, there has to be continuous education and ongoing training of those resources. So sometimes we undervalue those ongoing educational needs and lose sight of the fact that there really needs to be more time spent on educating all of the practice members so that they understand the core goals of the practice in general.
Yeah, and that's why a bona fide, sophisticated, well-organized, ongoing training and development program as a component of continuous quality improvement has to be present if a source of primary care would like to be identified as advanced primary care.
Well, this has been really fascinating to listen to and discuss. If you had the perfect environment in the future, and you could, look into a crystal ball 10 years from now, what would it look like in that crystal ball? What would be the best case scenario?
Best case scenario is we get away from fee for service for primary care. We carefully calculate what I call the future value of primary care. Primary care physicians are then compensated in advance, not on a risk basis, but on an expected service delivery basis, that 100% of the population within that practice will receive a minimum set of primary care services that border on, if not include, public health, and that all sources of primary care are given an equal opportunity to deliver this new form of primary care, in which case now, through this primary care as an investment strategy, we are meeting the needs of the entire community, a sort of primary care for all concept, rather than getting hung up and continuing to worry about uh, 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 coverage for all. I mean, I really think that if you start with primary care, the rest of the financing decisions for individuals becomes easier to make.
Dr. Constantz, I think this information has, been very helpful, and our listeners and the healthcare community at large are going to find it extremely valuable. If someone wants to learn more about your models or wants to, reach out to you for more information, how should they find you? Where should they follow you?
Actually, LinkedIn. Google me or search for me on LinkedIn. I've put all of my contact information there. I've put some of my narratives there, and actually have a couple of presentations I've made so that they can get a greater sense of who I am, what I am, and why I am. And but I would suggest they go to LinkedIn and find me there, and then reach out to me through LinkedIn, because I always like to know a little bit more about the folks I'm fixing to talk to, so that we can have a more robust conversation.
Thank you so much. I highly encourage everyone to, find Dr. Jed Constantz on LinkedIn. He has a lot of valuable resources there. There are a few webinars that are available, a few slide decks that you can look at. And you can learn a lot more about, the vision for value-based primary care, and really ultimately models of the future that I think are going to revolutionize healthcare. Over the last 2 to 3 weeks, we've experienced a decade of change in primary care to date, and a lot of these changes are going to stick as we move forward in the post-COVID-19 world. And I think we're going to find that healthcare is going to evolve at a faster pace than it had been in the past, because we now understand that we can evolve at a faster pace. So I highly encourage you to reach out, look for Dr. Jed Constantz. And Dr. Constantz, thank you so much for joining us today. It's been a pleasure. And to our audience, definitely make sure that if you enjoy this content that you follow us, subscribe. We are available on Spotify for the podcast, ALTIUS Answers, as well as Apple, and we also are on YouTube. Thank you very much.
Excellent.
Thank you for listening to the ALTIUS Answers podcast. For more information on anything you've heard today, please search for ALTIUS on LinkedIn or Facebook, or visit us at our website, www.altiushcg.com. That's www.altiushcg.com. Once again, thanks for listening. We hope to see you again in the future.